Hello everyone, welcome back to another video. In this video we're going to look at the management options available for patients with asthma. So in previous videos we've had a look at the different clinical presentations, so the different symptoms in the clinical presentations. We've had a look at the pathophysiology of asthma itself. We've had a look at the different investigation options, and today we're going to have a look at the management of asthma. So let's jump straight into the video. So we'll bring our patient back again, Mr. Whitecoat. Okay, now Mr. Whitecoat is finally wondering what are the different management options and the different medication that are actually available to control his symptoms. All right, so let's have a look at the long-term management options. Okay, so the very first thing that we can look at when managing asthma, bear in mind all these different management options are for patients who are over the age of 12 with a new diagnosis of asthma. So the very first thing that we can look at is something known as air therapy. Okay, so let's have a look at what air therapy actually is. Now, air therapy is essentially a combined inhaler. That's essentially what it means. It's a combined inhaler of formoterol and ICS. Okay, inhaled corticosteroids. So we'll go through the brief explanation of what both of these medications actually are, but we'll go into depth of the pharmacology of the different medication in asthma in the final video in the series. Okay, so what is formoterol? Formoterol is something known as a long-acting beta agonist. Okay, so what actually is a long-acting beta agonist? A long-acting beta agonist is essentially, so beta agonists are scattered around the airways within our lungs, so specifically beta 2 agonists, right? Now, when these receptors are actually activated, they cause bronchodilation, right, of the airways. So if we go back to what the pathophysiology of asthma actually was, it was the constriction of those airways that caused the obstructive nature of the airflow. So if we open up the airways, we dilate them, then it will hopefully reduce the symptoms that the patient actually experiences, right? So that's a reduction in the constriction of the airways itself, right? Now, what is ICS? ICS is an inhaled corticosteroid, right? Now, ICS, they come in little powders, right, in ICS inhalers, and this powder will then also line the airways, and it contains corticosteroids. So corticosteroids reduce the inflammatory response that actually goes on within the patient's lungs. So this also attacks one of the key principles of the underlying pathophysiology of asthma, right? So this reduces the actual inflammation of the airways, and the beta agonist opens up the airways, right? So in combination, then we can use those to then hopefully control the symptoms that the patient experiences. One thing to note about air therapy is that it is essentially a reliever therapy, right? So what does that mean? So air therapy is a regimen that's given to patients who have somewhat, moderate and mild symptoms of asthma itself. So that means that they only use the inhaler when it's actually required. So say they have an exposure to a common trigger, such as exercise is a very common one, maybe dust, pollen, those sort of things, and then if a patient experiences the symptoms of the wheezing, the chest tightness and the pain, the shortness of breath, then they can use the air therapy, which is the combined inhaler of formoterol and ICS, and then that will reduce the patient's symptoms. One other thing to mention with the LABA is that it's actually a long-acting beta agonist, right? So In contrast to short-acting beta agonists, this lasts way longer, typically around 10 to 12 hours. So the airways will remain open and patent when you use long-acting beta agonists as opposed to short-acting ones such as salbutamol that we've commonly seen, which is the blue inhaler, right? Now, the second thing in the pathway is something called low-dose MART therapy. So, when do we actually go? So we go from air therapy to MART therapy essentially when patients, symptoms are still uncontrolled. So if a patient's tried the air therapy of the using it as symptomatic relief, and if the patient continues to get ongoing symptoms, then we can go to low dose MART therapy. Now, what is MART therapy? MART therapy essentially it just means that it's a maintenance therapy. So as opposed to the quick symptomatic, use of the air therapy, MART therapy is a maintenance therapy. So this means that it's essentially in terms of its pharmacology, it's essentially the exact same drugs. So you still have the combined formoterol inhaler, which has both the ICS and the LABA inside, but the only differentiation is that it's the timing of the use, right? So this is used as a symptomatic control. This is used as a maintenance therapy. So patients will use this typically 1 to 2 times a day, and this means that there's ongoing bronchodilation and the reduction in the inflammation that the patient experiences. So a reduction in those for a longer period of time should hopefully control the patient's symptoms. Again, though, if the patient's symptoms are still uncontrolled on low-dose MART therapy, then you can probably guess what's coming up. It's going to be high-dose MART therapy, right? So, to no one's surprise, this is exactly what it sounds like. Exact same, medication, just at higher doses. So again, with the combined inhaler, you just have a higher dose of the LABA and the ICS. Okay. Now, the fourth thing is interesting because at this stage, what we're going to do is we're going to check the FeNO and the eosinophil count of the patient, right? Now, what is the importance of those? So FeNO, like we've mentioned in the investigations video, FeNO and eosinophils are typically raised with the patients who have asthma, right? This is a very typical biomarker. Now, if we measure these with patients, even after they've gotten the previous 3, management options within the pathway, then what happens is if these are increased, right, it means that the underlying inflammation in the inflammatory process is still going uncontrolled, right? It means that the eosinophils and the FeNO are still raised, and that means that the inflammation is still haven't been controlled by the drugs that we've given, and that means that we then need to either increase the doses or we need to add in more drugs. So what drugs can we add in after that? We can look towards LTRAs, okay, and long-acting muscarinic antagonists. So we can add these medication on top of the low-dose MART therapies for typically 8 to 12 weeks, and then reassess continually. But let's explain what LTRAs are. So LTRA stands for leukotriene receptor antagonist. What are leukotrienes? Leukotrienes are essentially mediators within the body, right? And when their receptors are activated, they increase the mucus production in the airways, the constriction, so they increase the mucus production, they increase the constriction of the airways, and this means that there is, it increases the amount of the underlying pathophysiology that's actually going on in asthma. So if we can block this receptor, right? That means that the leukotrienes can't have this effect, and hopefully that will help alleviate some of the symptoms. Now, long-acting muscarinic antagonists, what are those? So, muscarinic antagonists, right? They obviously, as inferred by the name, they block the effect of muscarinic receptors. Now, when muscarinic receptors, when they are bound, so when acetylcholine binds to those receptors, it causes bronchoconstriction, right? That's their action. So if we can block those receptors, we're essentially blocking the constriction, which then means that there is a, a long-lasting effect of bronchodilation within the airways. Okay, so that's if the FeNO and the eosinophil counts are raised. Now, let's assume that the eosinophil count and the FeNO are not raised, right? What does that mean? So that means that if after all this medication that the eosinophils and the FeNO are not raised, it means that it's an atypical presentation of the asthma, right? And that means that it's not going to be well controlled by the drugs because they target, the typical presentation. So then that means in that scenario, we would look towards specialist referral, okay? We will then refer them towards specialists who specialize within asthma management, and then they can look towards, allowing for better treatment and management of the condition. Thank you everyone for watching this video. This was the management for asthma. In the final video of the asthma series, we'll have a look at the pharmacology of the drugs that we've mentioned here. So we'll dive a little deeper into their mechanism of action and some of their side effects. So stay tuned for the final video, and thank you all for watching.